Hello, everyone. Welcome to the Glow Podcast. I'm here today with a very exciting guest. If you are new here, we are Tailored Marketing and we partner with organizations in health, wellness, and longevity space to fuel growth through strategic marketing and sales strategies. So if you are interested, drop a comment below. Thank you so much for coming on. I'm super excited to talk to you. If you would, I would love if you would just give a little bit of an introduction so the listeners know who you are.
Great. So my name is Dr. Leor Giladi. I'm a physical therapist by trade. I am the clinic director of the Hamilton and Bridgewater, New Jersey locations of Nexel Physical Therapy, which is an out-of-the-box, fitness-forward PT practice that uses out-of-the-box solutions to eliminate pain from the deepest root, so we can get back to living lives unrestricted and free.
Yeah, no, that's super awesome. And so I guess obviously most people know what physical therapy is, but what
hmm
kind of differentiates y'all from other physical therapy practices and where does your focus kind of really lie with obviously you said helping your clients and patients get better and, live healthier lives, but what really differentiates you guys on that physical therapy level?
Honestly, the biggest thing that differentiates us from traditional practices is the fact that we look at full bodies. And so we basically look for root cause solutions. And a lot of times in the PT field, and especially I noticed this a lot through my education, was we focus on either an individual body part or where pain is, not why pain is there.
Yeah.
And so oftentimes that can lead to, in many cases, that works great. But for a lot of people, that doesn't really solve the problem. And they end up getting stuck in either repetitive pain cycles or pain that doesn't go away. And sometimes they need a different approach. And so
Yeah.
what we do really takes the full body into account to find a deep root cause solution.
Yeah, and I feel like that's so important too, because obviously every part of our body is so connected. So it's
hmm
like, okay, if we're having knee pain, there's a reason for that knee pain. And obviously we need to look at the knee, but we also need to look at maybe it's our quad or our hamstring that is affecting it or like different parts too. So yeah, I feel like that's super, super important. And when you all are working with patients, what are kind of like their thoughts on this approach?
I mean, they love it.
Yeah.
So typically, because a lot of times our average patient population has tried and failed traditional care multiple times, whether that's working with another physical therapist, whether that's like orthopedic management through injections or surgery sometimes, or they've seen chiropractors, whatever it is, they've tried a lot of things and they haven't quite found an answer. And so by the time they get to us and we talk about the whole idea of like the full body solutions, the integrated care, the looking for root cause, they're usually quite ready to get an answer.
Yeah, no, for sure. Well, and they probably haven't seen that, like, especially if they are going to like a specialist or something, they're
hmm
really just focused on that one specific piece of it rather than the full body. So they're probably like, okay, this is different. Like this looks promising.
100%. I mean, I had an
Yeah.
assessment this morning with somebody who she started having back pain about 8 years ago, no incident, just atraumatic onset, and has like it's gotten worse over time. She's been managed it really well with like orthopedic care, with some chiropractic care, and it helps her feel better. But the problem is still there, and it holds her back from the life that she wants to live, like in terms of like her training potential.
Yeah.
And so she's had imaging done, she's had all these things, and there's nothing, there's no findings because there's nothing structurally wrong with her. And so somebody like that is just like, please explain to me what's happening. And they're usually very ready for a clear answer.
Yeah, no, that totally makes sense. And so when you say like the full body approach, how does that kind of, I guess, tailor your treatment plans? Like, are you all like when you're doing physical therapy, is it's like, okay, maybe we have like a knee issue, but we also want to strengthen your back or strengthen your
hmm
hamstrings. And like, what does that kind of look like?
No, it's a good question. So first thing to kind of get into is this idea of like, there's no doing of physical therapy. Physical therapy is more of like a practice overall. It's a philosophy. Like you don't go to a dentist for dentistry. You go to a dentist to have like your teeth cleaned or have somebody look at something
Yeah.
or repair a piece. And so my first thing is I always like to work on shifting that perspective a little bit. Physical therapy isn't a thing you do. A physical therapist is the person you work with.
Yeah.
And so they come in, and what we do is we diagnose like what are the things this person is limited by? Is it one, is there something local that's happening at the area where they're feeling pain? Is there something biomechanical that we need to address? Is it something lifestyle based that we need to get into? Is it a strength issue, capacity? Is it neurologic? So we kind of like how we approach it really depends on what the individual specific needs are. So we actually do very like deep, detailed evaluations, and most people before they even start a plan have had like 2 to 3 contact points with us before we even get started, so that we can
Yeah.
really get all this like depth of information and really help them to find the root cause and know where to start. It's all
Yeah.
about knowing where to start.
Yeah, no, and I feel like you were saying too, the evaluation portion of that is so important because it's like, okay, we've got to figure out like where you're at, where you want to go, what your goals are. If stuff's not showing up, like the example you gave for this morning on a scan, like we're gonna have to go off of basically what you're telling us is going
Hmm.
on because we can't see anything. And I feel like that's probably for patients like even more frustrating is when nothing is showing up and they're like, okay, what is wrong with me?
Yeah. Well, and so that's what's interesting is nothing's obvious to them, but there's a lot of things that become obvious to us. And so we do a combination of, yeah, subjective report makes a huge difference. What they feel, where they feel it, how the pain behaves, symptom behavior is a really big indicator of like what might be going on, but it's not enough by itself. And so the way like the assessment process works is we look for congruence at a series of different steps. And so one, it starts with subjective reporting, and as people do that, we start to build a hypothesis of what we believe might be happening, and why they might be either putting too much stress or force into these areas repeatedly. And like from this in behavior, like, do we believe this is neuromuscular? Do we believe there is a structural component to it? On and on. And then from
Yeah,
there, we get into our range of motion testing, which kind of like highlights, like passive range of motion will tell you your options at baseline.
yeah,
Options for movement determine what you can do actively. Like if you don't have passive motion in a specific area, you definitely can't do something actively in that area because if you can't access position, you can't control it. And so now that's going to eliminate a series of options from your movement profile, right? And so now when you have to solve problems in the world, whether you're squatting, running, jumping, climbing the stairs, emptying the dishwasher, whatever it is,
yeah,
if you have a set of options that are no longer available, you now have to rely more on different options. And so what we do is we start next with range of motion, and we look at not just range of motion in the joint that you're bothered by, not just the range of motion in the joints next to it, but we do full body 3D maps. I do, even no matter where your problem is, I check hips, shoulders, I do it on your back, I check internal, external, side lying stuff. And basically it helps me to build a 3-dimensional map of two things. One, your body's movement capabilities, and two, I can make a broad assumption of where your center of mass is in space relative to your base.
yeah,
And that's going to have a huge influence on muscle activity, force management, force distribution, stress and loading.
yeah,
And then I can use that information to go, now I understand why this part of your body hurts. And now we have to reverse engineer how you got here.
yeah. No, it's almost like it's like a puzzle kind of like,
It's a puzzle.
okay. Yeah. It's like, okay, we're putting all these pieces together to see what's going on, and the body is so complex.
Hmm.
So it's just almost like an impossible puzzle, but y'all are solving it.
Well, and that's the thing with complexity is all complex systems operate based off of a series of simpler rules. And so we can
Yeah.
use those simpler rules to figure out what might be happening. But the interesting thing with complex systems is you can't identify cause and effect in advance. And so like in a simpler system or something that's more straightforward, you can go, if I do X, then Y will happen. Like I pull a spark plug out of my car, I'm not going to get anywhere. Like the engine's
Yeah.
not going to go, right? And I know this will happen. If I take certain range of motion away from somebody, I can't predict exactly what will happen because the body is highly adaptable and complex, and it might find alternative solutions that I didn't predict. And so what we have to do is we get all the data, we combine the subjective report with observation of like posture and movement, and then we do our range of motion testing, and we determine what we think will happen. And then we have to do the fun part of intervene. And so then we input into the system a safe to fail experiment, if you will.
Yeah.
And then we see what the system spits back. And so if I use my simple rules and understanding of human physiology and I go, if I do this based on what I'm assuming, this next thing should happen. And if it does, great. We know exactly where we are. Things are going great. If it doesn't happen that way, then that means there's some other data point that we need to figure out. But that experiment gave me more information. Now I can seek different solutions. And so typically we use a very continuous test retest model to sort of go and test the hypotheses and work closer and closer to the underlying truth of the situation. And
Yeah.
then the more and more we experiment and the more we work with a person, the better feedback they give us. the more diligent they are with their homework, the cleaner the experiments become, and the faster we can get to a solution.
Yeah. No, that's super, super cool. And I feel like you explained it like so well. It's like really figuring out like, okay, if they're not able to do that, then like with their range of motion, then
Hmm.
basically they're having to use a different muscle or part of their body that they really shouldn't be having to use. And then it's putting strain on that part of their body. And that's why we're seeing this issue.
Yep. It's like I like to give clients an analogy of like it's like a group project back in school
Yeah.
where everyone should be doing their part,
Yeah.
but sometimes some people don't and other people pick up more work.
Yeah.
That part that hurts tends to be doing the whole thing.
Yeah, they're picking up that part of the body or like that person,
Hmm.
and your analogy is picking up all the slack, and so they're like burnt out, and it's the same with your muscles. They're burnt
Hmm.
out.
Yeah, they're
Yeah.
just working too hard.
Yeah. No, that completely makes sense. And are there like reoccurring issues that you kind of see people that are coming to y'all for, or is it really just completely different based on every single person?
You see reoccurring issues like one person who comes back for multiple issues or the same types of issues showing up often.
Yeah.
Which one are you
Oh,
asking about?
the same issues kind of coming up often, I would say.
Okay. Yeah. So yes, back, knee, hip, and shoulder. Those are the four primary order things, and typically in that order of those are the things that we see the most often. And
Yeah.
they're often like either infrapatellar, like for let's say for a knee, I typically see one of three things. There are some people who come in with like wild cards that are a little bit different, but the
Yeah.
most things I see is either right under the kneecap, just above the kneecap, or on the inside of the knee, any sort of like half crescent moon around the inside of the knee area.
Yeah.
Now, those are the three most common. But the interesting thing is I know mechanically at the joint itself, it all occurs for similar reasons. But why the knee is doing that specific thing, why the knee is using that strategy, can be highly different for every person. And
Yeah.
so locally at the knee, X strategy is occurring to manage movement, force, etc. But why that person is utilizing that strategy changes for everyone, and that's why we do such a deep evaluation.
Yeah. No, it's so crazy because, yeah, actually, I have like knee issues. So I
Hmm.
can totally relate to that on like a level. And I've kind of figured mine out. But like, I know that, like, yeah, anywhere where you have a joint, and then I feel like just backs are so common in general because I don't know why. I'm sure you probably have a better idea of that, but I feel like those ones are the ones that you hear the most often, like where we do have joints because there's more room for error, kind of. Or I don't know if you have a different hypothesis on why that occurs.
Well, there's a little bit of a room for error. Actually, you're right about back pain. The incidence of back pain, 80% of the human population will have back pain at some point in their life.
Yeah.
And that is across all demographics. It is one of the most consistent things of being a human is having back pain at some point,
Yeah.
right? And part of the reason is one, like you're right, there's a lot of stuff that goes on there, but two, the lower back is a sort of a bridge. It's part of the bridge between the thorax and the pelvis, right? And
Okay.
so it tends to, there is a lot of stuff that has to run through that area. The other thing is that lower back pain is also closely associated with kind of like the disability related to lower back pain is also very closely associated with people's perception of what the problem is, what it means, and their fear of potential outcomes. And so one of the things that really helped me to understand this is I got a little into some like a bit of a research rabbit hole at one point where I was trying to understand like why is back pain so big? Like why is it such a big thing with back pain? And what's interesting
Yeah.
is since we've started recording this stuff like in the 1900s, somewhere early on, the 80% has been a consistent, ongoing, not changing thing. But they
Wow.
found that around, and that's just like human experience, and that it's like
That's
between
crazy.
desk workers or active populations, so they do find that the more active you are, the less back pain you have generally.
Yeah.
The thing that was really interesting is disability rates associated with back pain really started to spike in sort of like the mid 80s. And
Okay.
there's no real like answer on it. Based on all of my reading, my current theory and the way I kind of look at it is the thing that became widely available at the same time that disability rates spiked was imaging. People could actually see inside of their bodies now.
Mm.
And so there's a lot of like normal structural changes that happen as we live and as we move and as we age. And
Yeah.
so, like for example, if I were to grab 100 people off the street with zero pain at all, and I were to MRI their lower backs, about 40% of them would have disc herniations or bulges, and they have no symptoms at all. And so, like structural change doesn't always indicate that you will have pain. It's not how pain works.
Yeah.
And the way I like to give it to people is like if you were to see an elderly person with wrinkles on their skin, would you think there's something wrong with their skin?
No.
No, of course not, because it's a natural aging thing.
Yeah.
The same thing. This is just wrinkles on the inside of us, right? But people start to see this stuff and they go, "My God, my spine is changing. It's falling apart." And then you add in like unhelpful narratives from the medical profession, which are fortunately getting better as we become much more educated on like psychosocial influence. But you combine imaging on the inside with unhelpful nocebo-based narratives, and people become very afraid.
Yeah.
And so fear spikes disability because if they're worried that if I move, I'll worsen the problem. If I worsen the problem, it's my spine. If my spine goes, I'm paralyzed. And people are very extreme in these beliefs because they're not informed. And
Yeah.
so the last thing that really like held this in for me, what I thought was really fascinating, was I read a series of research that was done on physical therapists with back pain treating patients with back pain. And on average, and the one of the criteria for the people who were in the study was they were out of work on disability because of their back pain. So what's interesting is when going through surveys and testing and like the subjective reports and everything, the PTs who were treating these people, 40 to 50% of them had higher pain levels than the people who were in the treatment with disability.
Wow.
The difference is the PTs can contextualize the pain that they're feeling. They understand what it is, what it means, why it's happening, how to manage it, modify, etc. And so as a result, it is no longer threatening to them or not as
Yeah.
threatening, and they can tolerate the discomfort better.
Yeah.
And so when I think about like going back to what we do in our practice, back pain is such a big deal, not just because it's a physical bridge between two highly moving parts of your body, but because there's a lot of emotion attached to it.
Yeah.
And emotion and fear can highly magnify discomfort, which is
That's
why
true.
anybody who comes in and works with us, part of the initial process isn't just, well, we're all about long-term solutions, but giving people tools to understand what they're feeling, manage it in the moment, and eliminate pain early on is like paramount to one, building a therapeutic alliance and getting trust. And two, making it so that a person can do the homework they need to make the long-term change. Because if they're hurting all the time, doing your homework's going to suck.
Yeah. That's true. Well, and I feel like pain is like it's so complicated, because
Hmm.
it's very subjective. Each
Hmm.
person has completely different levels of like what they would call a 10 out of 10 for pain. Like if you ask one person and then you were to be able to stimulate that exact level of pain
Hmm.
on someone else, their level of the threshold for what they can withstand with pain is going to be completely different. And I find that so interesting because there has to be some of like it almost makes me think of like that thing where people say like the worst thing that ever happened to you is the worst thing that ever happened to you. And like when you're 5, that might be like your ice cream cone like falling off of the cone and you don't have your ice cream. But like normally when you're 20, something worse than that has happened to you. But like you're losing your ice cream cone wouldn't even matter at that point.
Hmm.
And so it makes me think that pain is almost similar in that sense. And I don't know if you have a better grasp on kind of how someone is able to withstand a lot more pain than someone else.
Yeah, I do actually have some perspective. Pain science is one of my like little side projects because I find it fascinating as well.
Yeah.
But I will also say dropping your ice cream is always devastating, no matter how old you get.
We don't want
But
it to happen.
we don't want it to happen. But
Yeah.
when it comes to this threshold management, it's not just pain. This happens for everything in all humans. And like the things that you're exposed to create a new baseline for your future experience. And so I think of it like progressive overload in the gym, right? And so
Yeah.
progressive overload is the concept of like continuously adding a greater challenge over time. And so if I can start curling a 20-pound dumbbell, for example, and that's my threshold, I can only do that for one rep, all right? But I train, and I build up, and I get up to like a 50-pound dumbbell. That 20-pound dumbbell feels really easy. It's no longer problematic to me,
Yeah.
right? And so I have greater scaling, greater perspective, and my body has an increased tolerance to bigger, more intense things. And so this whole idea of like pain perspective or pain perception changing based off of your experience is just like that. And
Yeah.
so you might think something's a 10 out of 10 until you feel a 10 out of 10. You're like, oh, I was wrong. My scale just got bigger.
Yeah.
And now this thing that was here at the top of the scale actually now sits in the middle. And then maybe you have another experience that changes that scale again. And you're like, update. And it continues happening like that. Other thing that happens is the frequency within which we handle discomfort and the strategies that we have to manage it also make a big difference. And so you see this a lot. Like I did a lot like, SEAL training stuff, or I got into like Goggins stuff for a while. And he talks
Okay,
about this whole like
cool.
hardening the mind, right? But I see it also in the gym, right? People who have never really worked out before and they get into resistance training and they feel like the strain in their muscles, they call that burning pain.
Yeah,
Like
wow.
they do it all the time. I feel pain here. I'm like, can you like let's work on vocabulary.
Yeah.
And I give them like a list of options of like other possible words, and they'll like pick from it. And it's usually not pain. They
Yeah.
just don't have any other way to describe it because it's such an intense sensation for them.
Yeah.
But then they do it for a while, and it normalizes. So this is one of the things with the brain that helps with pain. And I could continue riffing on this if you want me to, but I don't want to like go all in
No,
if
no, no,
you're not
no.
ready.
think I think it's so interesting because like it definitely is like based on past experience, like you said, and then like it is like your mind, because that's all your mind is like based on past experience. And like one of the things that, I mean, this is like a funny thing, but it's like you can put those simulators on like men for like
Hmm.
menstrual cramps and stuff. And like they're like going crazy. But like for a woman, you're like, okay, I know how this is. Like I've had this sensation
Yep.
before.
Yep.
So
I can recognize this. This has meaning to me.
yeah, no, and so I think the way that you explained it is it makes so much sense. It's really just like based off of past experiences and like, okay, I've felt this before and like it can even be something like doing a bicep curl, like you were saying, or like I go to the sauna all the time, so I'm like used to it. But for somebody
Hmm.
going to the sauna for the first time, they're like, oh my gosh, like what is this? Like this is absolutely terrible.
Yep. Yeah. Exposure over time has a huge thing. Now, this is also fun if we're already on the pain topic. One of the interesting things with chronic pain is your nervous system will sensitize the pain experience. And so what happens is like a two becomes a four becomes a six, and it scales upwards over time. And the only way we can resolve this, because that process happens due to like actual plastic or structural changes to the brain based on time, you actually have to retrain the neural wiring through exposure. And you have to start doing that process of like giving them doses of non-threatening, non-painful stimuli to rebuild their expectations or rebuild their sensitivity.
Yeah.
One last thing while I'm on pain, because I think this is something that a lot of people don't get about pain, and while we're talking about it, it's an important point for people to get.
Yeah.
Pain is not a sensation. Pain is an experience, right? Pain is a brain-driven phenomenon, and that doesn't mean that it's all in your head. We're
Yeah.
to be very clear about that. It just means that it is brain-driven. And so what I mean by that is there are nine individual regions of the brain that create the pain experience. Everything that includes memory, it includes your amygdala for fear. It has things for sensory, motor, smell, like all of this is in there, right?
Yeah.
And so what happens is before you feel pain, your body will take in a bunch of data from the physical body, like nociception, which is the nerves coming in from the body that kind of give it information about like really strong stimuli, and then it blends that with knowledge, past experience, emotion, etc. And then it goes, is this thing a threat to me?
Yeah.
And if it feels like a threat, pain exists. If it's not a threat, pain does not. The bigger the threat, the bigger the pain. And
Yeah.
so thinking about pain, pain is not an indicator of damage to a body. Pain is an indicator of a potential threat that your brain is perceiving. And so pain is actually one of our best friends.
Yeah.
People think of it as a bad thing, but if you ever met a person who doesn't feel pain, their lives are extremely hard.
Yeah. No, that's so true. Like I feel like that's such a good way to think about it too. It's a perceived threat rather than actually like a bad thing. Like it's your brain trying to communicate with your body like there is a potential issue here. Like let's get this fixed.
That's it. Let's do something about this. And
Yeah,
so if the pain,
exactly.
Mhm.
Go
And so
ahead.
if the pain doesn't go away, that just means you didn't figure out the problem.
Yeah. And it's like a sign like, okay, like let's get this figured out. Like I'm gonna keep telling you until you listen to me.
Bingo. And
Yeah.
so I encourage anyone who has pain, have tried other things, and the pain is still there, keep looking for an answer. It's out there
Yeah.
somewhere.
Yeah. No, that's so cool. And let everyone know. So, what is the best way to find my next level online and find the practice? And then I will also put the links in the show notes as well. So everyone has easy access to it.
Absolutely. So we have four locations. three in New Jersey, one in Pennsylvania. We have Marlton, New Jersey, Hamilton, New Jersey, Bridgewater, New Jersey, and Southampton, PA. Our website is just my next LVL, so there's no E's in the level, .com, and you can find us on Instagram under the same handle, my next LVL. Those are the best ways to get to us. We have easy access, like you can reach out messages from there. You can DM us on Instagram, very easy to get in touch. And if you have some kind of pain that's not quitting, you've tried a lot of different things and nothing seems to give you the answer, but the pain is still there, please reach out. Or if you have pain that the same pain that keeps coming back, no matter how many times you get rid of it, you have not solved the problem yet, you just patched it.
Yeah. No, awesome. Well, thank you so much for coming on. I really, really appreciate it, and I appreciate your time.